Welcome to today's Explainer. We are diving headfirst into the incredibly high-stakes world of medical diagnostics. This is a place where missing a single subtle signal can literally mean the difference between a routine discharge and a life-threatening crisis. Picture it. When a patient arrives in severe distress, the clinical environment is just absolute chaos. It's loud, it's fast-paced, and it is completely overflowing with data. The challenge here isn't finding information. The real challenge is filtering it. You have to be able to separate the vital, life-saving clinical signal from the overwhelming background noise.
So here's the ultimate question, right? How do you actually spot that hidden, lurking emergency when, on the surface, the symptoms look exactly the same as a minor, everyday ailment? Well, today's explainer focuses intensely on what we call the dividing lines. We're going to look at the critical and honestly sometimes incredibly subtle clinical signs that differentiate routine issues from catastrophic, time-sensitive emergencies. We'll be zeroing in on two major domains where these dividing lines matter most: severe soft tissue infections and third trimester obstetric bleeding.
Okay, let's dive into Section 1. Cutaneous infections, surface to deep.
So, we're going to start our diagnostic baseline right at the surface with erysipelas. This is a superficial infection of the skin that completely spares the deeper subcutaneous tissue underneath. The classic microbial culprit here is group A streptococcus. And because this infection is essentially trapped up in those upper dermal layers and lymphatic vessels, it presents in a very specific, visually distinct way. And wow, this brilliantly illustrates exactly what we're talking about. Look really closely at the borders on this patient's skin. Erysipelas is characterized by these incredibly sharp demarcations between the infected, inflamed skin and the normal, uninvolved tissue right next to it. The infected area is actually physically raised above the surrounding skin. It's almost as if someone took a red marker and drew a distinct, solid line. This is your classic, uncomplicated, superficial signal. But what happens when that infection decides to go just a bit deeper into the subcutaneous tissues? Well, that's when we cross the line into cellulitis. And here is a fundamentally crucial diagnostic dividing line: the simple presence or absence of purulence, which basically means pus or drainage. On the left side here, non-purulent cellulitis presents with your typical redness and swelling and is usually caused by streptococcus. But over on the right, the very moment you see fluctuance or purulent drainage, the entire game changes. That purulence is a massive, screaming signal pointing straight to Staphylococcus aureus, and very often MRSA. Your choice of antibiotics has to pivot immediately to cover this entirely different bacterial threat. Moving on to Section 2, the necrotizing tipping point. Now this is where things get genuinely terrifying. Necrotizing fasciitis is a true surgical emergency that is actively masquerading as a simple skin infection. The absolute most critical warning sign here, the loudest signal you can get, is pain out of proportion to the physical exam. If the skin just looks a little pink, maybe a little swollen, but the patient is screaming in agony when you barely even touch them, you absolutely must suspect deep tissue destruction. Other giant red flags include rapid progression over just a matter of hours and crepitus, which is this horrifying feeling of gas literally crackling under the tissues when you press down. We also rely on the LR-NEX score, which audits lab values like white blood cells, sodium, and glucose to help calculate the exact probability of this devastating disease. Now, what's really interesting and frankly quite grim about this slide is that dusky, purplish discoloration and the severe underlying tissue necrosis you see. This contrasts so sharply with the simple red surface of erysipelas we looked at earlier. This is definitely not just a surface problem anymore. The bacteria, which is often a mix of aerobes and anaerobes, or sometimes just a super severe group A strep, are aggressively spreading through the deep fascia layers. They are literally destroying blood vessels and nerves as they go. Standard IV antibiotics alone will not save this patient. You need immediate surgical debridement to physically remove the dying tissue. Recognizing that signal of pain out of proportion early on could literally be the difference between saving a limb or losing a life. Section 3, obstetric bleeding, abruption versus previa. All right, let's completely shift gears to catastrophic third trimester bleeding, where you are suddenly fighting to save two lives at once. You have to immediately distinguish between a placental abruption and a placenta previa. Looking at the left, we have placental abruption. This is the premature separation of the placenta from the uterine wall. It presents with painful, dark bleeding and a very firm, almost woody-feeling uterus due to the intense contractions. If we look at our severity invasiveness resuscitation matrix, if this patient becomes emergent, you are looking at an immediate emergency C-section to prevent fetal exsanguination.
Now, on the right, we have placenta previa. The signal here is totally different. It's painless, bright red bleeding. So painful and dark versus painful and bright. That is your dividing line.
Okay, please pay close attention to this because it's absolutely crucial. Knowing that dividing line leads us to a massive hard and fast rule in emergency obstetrics. Never, ever perform a digital vaginal exam on a pregnant patient with undiagnosed third trimester bleeding. If they happen to have a placenta previa that is covering the cervical opening, your fingers could literally puncture that highly vascular placental tissue. That single dumb mistake can instantly trigger a massive uncontrollable maternal hemorrhage. You always confirm the placenta location via ultrasound first.
Let's move to section 4 and see how this builds. Fetal distress and uterine rupture.
So picture this. You've got a patient in active labor. Her contractions are strong and steady. Then, out of nowhere, there is a sudden, complete cessation of contractions accompanied by intense tearing pain. You do an exam and you notice a sudden loss of fetal station. What does this actually mean? Well, it is the pathopneumonic signal, meaning it's a dead giveaway of a uterine rupture. The baby has actually receded back up into the maternal abdomen, and you might even be able to feel the fetal limbs right through the mother's abdominal wall. In our resuscitation matrix, this is the absolute highest critical tier. It requires an immediate exploratory laparotomy for delivery and, very likely, a uterine repair or hysterectomy to stop the bleeding.
Section 5. Signal over clinical noise, fetal heart rate monitoring.
Now, to actually catch these horrific issues early, we have to be able to decode the visual signals of fetal heart rate monitors. First up, the early deceleration. Notice how the dip in the fetal heart rate up top perfectly mirrors the mountain-like curve of the maternal contraction down below it. The onset, the absolute lowest point, and the recovery all happen at the exact same time as the contraction. This is a totally benign, normal response. It simply means the baby's head is being compressed as the uterus squeezes during labor. It's just clinical noise, it is not an emergency.
Now, contrast that normal response with a late deceleration. Look closely at the timing here. The maternal contraction peaks, but only after that peak does the fetal heart rate begin its slow, gradual drop. And the recovery, it doesn't happen until well after the contraction is completely over. This shifted timing is a terrifying signal. It indicates uteroplacental insufficiency, which is just a technical way of saying the fetus is experiencing a dangerous, prolonged lack of oxygen. This is a massive red flag that we often see with things like placental abruption, and it demands immediate intervention to prevent fetal asphyxia. So the crucial point here is comparing those smooth rolling curves we just saw to the variable deceleration. Notice how incredibly abrupt and jagged this drop is? It happens rapidly, dropping 15 beats per minute in less than 30 seconds. And true to its name, its timing varies. It doesn't always perfectly align with a uterine contraction. These sharp V-shaped or W-shaped drops point directly to the umbilical cord being compressed. When that cord gets pinched, the blood flow stops, and the fetal heart rate just plummets instantly.
To really cement this diagnostic knowledge, we use the absolute classic Veal-Chop mnemonic matrix. Honestly, if you memorize this one slide, you can instantly decode fetal heart rhythms in practically any high-stakes scenario. So, V is for variable decelerations, which connects to C for cord compression. E is for early decelerations, which means H, head compression. A is for accelerations, which means, oh, okay, the fetus is doing great, no worries there. And finally, L is for late decelerations, which spells P for placental insufficiency. Veal-Chop. It's a remarkably simple tool, but it cuts right through the clinical noise when you need it most.
So, what does this all mean for us? Whether you're staring at a red, swollen patch on a patient's leg or analyzing the jagged, jumping lines of a fetal monitor, the data is always broadcasting. The question isn't whether the disease is speaking, it's whether you are tuned into the right frequency to actually hear it. Tomorrow, when the clinical noise is deafening and the pressure is on, will you spot the signal before the tipping point is reached? Thanks for joining this explainer. Keep your eyes open for those dividing lines, and we'll catch you next time.